Hello everyone. Today I will discuss recent developments in the management of diabetes with a focus on injectables which are not insulins. So today's topic would be non-insulin injectable anti-diabetic agents which are entirely based on incretin. I will discuss what is incretin and how these therapies have come up and what is their impact in the management of diabetes and outcome. We will be using certain abbreviations which are almost known everywhere. GLP-1, GLP-2 are the glucagon-like peptides 1 and 2. GIP is glucose-dependent insulinotropic polypeptide, or also known as gastric inhibitory peptide, and DPP-4 is enzyme dipeptidyl peptidase 4 enzyme. Now, what is the role of incretins? Incretin is a name given to insulin secreting substances which are protein peptides which are released from the gut in response to glucose ingestion. The responsible part of this secretion is that they are responsible for early and late phase of insulin secretion, and most importantly they account for 50% to 70% of the total postprandial insulin secretion. Therefore, their role is tremendous in the physiology of glucose homeostasis. Incretin effect is impaired in type 2 diabetes mellitus. Now, among the important incretins which we will be discussing, there are actually three: GLP-1 and GLP-2, GIP, and oxyntomodulin is coming up. In this presentation, we will not discuss oxyntomodulin, but we will be discussing GLP-1 based therapies mostly. Now, natural incretins, that is GLP-1 and GIP, they have very short half-lives because of rapid and quick hydrolysis by the enzyme DPP-4. Therefore, they are not used clinically. They cannot be used clinically. And therefore, synthetic or semi-synthetic structurally modified forms of GLP-1 are developed and they have become important therapy. Now, GLP-1, the incretin, acts on receptors which are distributed widely, particularly in GIT and brain, and in the GIT they are found in pancreatic alpha beta cells, in the small intestine, colon, and vagal afferents in the intestine. Also in certain areas of brain which are involved in food intake, that is feeding center or satiety center. Now, their nature is they are transmembrane G protein coupled receptors with moieties outside the cell membrane and inside the cell membrane for initiating second messenger activity. And one of the second messenger is that there is increase in cyclic AMP, and that subserves a number of the functions such as beta cell secretion or neuronal activity in the satiety cell. Now, among the drugs which are now available as incretin based therapies, they can be called as GLP-1 receptor agonists. They stimulate the receptors. And these GLP-1 receptor agonists are actually resistant to inactivation by DPP-4 enzyme. So they have a longer half-life and longer stay in body and will exert their anti-hyperglycemic and other actions. Now, one peculiar thing is that they are less likely to cause hypoglycemia because their impact on insulin secretion or glucagon secretion are glucose dependent. Higher the glucose, higher the insulin release. Lower the glucose, more the glucagon release. In this way, glucose homeostasis is tightly regulated. Now, among the agents which are available, I have classified them into two groups. One group is extendin 4 molecule based drugs, and second is the structural modification of human GLP-1 molecule. And among the extended 4 molecules, 3 agents are there: exenatide, the original one, exenatide ER, which is long-acting, and lixisenatide, which is once daily. Now, though GLP-1 structural modification are albiglutide, which was developed but withdrawn due to limited prescribing, and then came dulaglutide, liraglutide, semaglutide, and tuspeglutide came up in 2001, but because of unwanted effects, that development was stopped. So now we today have 3 important drugs: semaglutide, liraglutide, and dulaglutide. Among them, they are usually longer acting, but oral semaglutide will be a daily acting drug because of short. Now, later on, dual agonists have also been developed, and one of the drugs is tirzepatide, which acts on GLP-1 and GIP receptors. This agent has proved to be very useful in the management of type 2 diabetes mellitus when given subcutaneously once a week. So the therapy becomes easier. Now, just to complete the list, teduglutide is a GLP-2 receptor agonist not considered for the diabetes mellitus, but currently it is being investigated for the treatment of short bowel syndrome or blind loop syndrome. Now, in general, weekly drugs have longer half-life than those given for daily use. Pramlintide is not incretin, but it resembles because it complements the effect of insulin. It is not related to incretins at all. Now, as a class effect, studies, multicentric studies, meta-analytic studies have shown that incretin mimetic drugs or GLP-1 receptor agonists have pleiotropic effects. That is, effect is not one but many effects unrelated to each other. Now, the most important effect is they enhance insulin secretion following oral glucose intake, that means after meals. They reduce fasting, PP sugar, and importantly hemoglobin A1C levels, and may also increase insulin sensitivity level. Therefore, the endogenously secreted insulin may have a better peripheral actions. Other important effect is they reduce glucagon secretion, they improve lipid profile, reduce cardiovascular risks, reduce body weight and blood pressure. That's very important. Weight reduction may be attributed to decreased gastric emptying, increased satiety, which is central, and reduced food intake. Shorter acting drugs show better effect. A central anorexic action has also been proposed because they act centrally on the GLP-1 receptors. These actions are found to be salutary in the management of type 2 diabetes mellitus, that is majority onset diabetes mellitus. Currently, they are not indicated for the childhood diabetes, that is type 1. Now, let us discuss individual drugs, key points. Exenatide, extended 4, the original one obtained from saliva of venomous lizard Gila monster, has anti-hyperglycemic effect, and this agent is resistant to DPP-4 inactivation but has a shorter half-life, and it had been used as a subcutaneous injection, was available as pre-filled syringe. Now, it must be given twice daily, 1 hour before breakfast and dinner. Effects are that in studies up to 30 weeks, exenatide lowered hemoglobin A1C by 0.5% and reduced weight by 3 to 5 kg. Exenatide was to be given twice daily, and that was a problem. Therefore, exenatide extended release formulation was developed, and this agent could be given 2 milligram subcutaneously once a week only. The dry powder is to be reconstituted and injected. Exenatide had one important problem, and that is development of antibodies because of its protein nature, and high titer were found in 0.6% that reduced the anti-hyperglycemic actions and produce hypersensitivity. Lixisenatide came up later on, which was a synthetic analog, and here the proline is deleted and 6 lysine residues are added at the C terminal of the GLP extendin 4. However, it has a short half-life and given subcutaneously 10 to 20 microgram once a daily before breakfast. So it is a once a daily drug. Impact is same, that is 0.4 to 0.6% reduction in hemoglobin A1C and a loss of weight by 1 to 3 kg. Being extending 4 derivative, it also developed antibodies in as much as 70% recipients. Problem with these agents. Now, among the important drugs in the second group, that is structural modification of human GLP-1, liraglutide is one important agent in which GLP-1 is non-covalently bound to albumin by an acyl chain. It becomes longer acting with a longer half-life of 11 to 15 hours and duration action over 24 hours. It has to be given subcutaneously by injection. Now, glycemic control is improved when given alone or when added with sulfonylurea or metformin. And in multicentric post-marketing studies, it lowers the risk of death, non-fatal myocardial infarction, non-fatal stroke, and with fewer episodes of hypoglycemia. So, the MACE-3 or MACE-4 point cardiovascular risk factors are reduced. Weight loss is also observed 2 to 3 kg, and blood pressure reduction, particularly systolic BP reduction, was also there. It has been tried in obesity, and the usual dose ranges from 0.6 to 1.8 milligram subcutaneously once in a. Semaglutide is further development in which an alpha amino isobutyric acid substitution at position 8 of the GLP-1 is done, and that makes the molecule longer acting and DPP-4 resistant. Now, another change is at C18 fatty diacid chain is also attached. Now, that makes it a longer acting with a half-life of 7 days. So, semaglutide subcutaneous has a half-life of about 7 days. Therefore, it is used once in a week and available as 0.25 to 1 milligram pre-filled. Further development was oral semaglutide was developed, and oral formulation was developed by addition of a absorption enhancer called as SNAC. 300 milligram was added and it becomes more bioavailable orally. The unique position is that oral semaglutide is absorbed from stomach like alcohol and not in the intestine. This absorption enhancer facilitates absorption from paracellular species, that is gastric paracellular species, and by loosening tight intercellular junctions. In circulation, SNAP dissociates and semaglutide exerts a therapeutic action. Oral tablet is 1 milligram, 3 milligram, 7 milligram and 14 milligram. It is to be taken once in a day. Initial dose is 3 milligram for 1 month and then dose is increased to 7 milligram, and it is taken on fasting, and meal is to be taken half an hour later on. Maximum dose used in trials have been for 10 milligram. Weight reduction with semaglutide has been observed in the larger trials. 68-week step 2 trial showed that a dose of 1 milligram and 2.4 milligram subcutaneously along with lifestyle modifications reduced weight by 7%, to 9.6% dose dependently as against placebo, which produced 3.4% by lifestyle modification. Therefore, once weekly subcutaneous 2.4 mg semaglutide was approved for weight loss in obesity in last year, that is June 2020. Dulaglutide is a newer development in which two GLP-1-like molecules are covalently linked to the Fc fragment of the human IgG4. It is engineered to prevent the Fc gamma receptor dependent immune response, so it has less immunogenicity. That is important as compared to exenatide. It is also resistant to DPP-4 inactivation that makes the molecular size larger, so rapid renal clearance is reduced, so it stays in the body longer. The impact of dulaglutide are tremendous. Reduction in the hemoglobin A1C up to 1.6% and weight by 1 to 3. Now the drug is bioavailable up to 65% when given subcutaneously with a half-life of 5 days, so it is given once weekly, and volume of distribution peripheral is 5 liters and the central is 3 liters. Clearance is also low, and this drug is being a protein is metabolized by proteolysis. Currently, it is recommended as 0.75 mg or 1.5 mg subcutaneous prefilled syringe to be given once in a. Tirzepatide have been approved in this year, May 2022, and this agent is the first example of dual receptor agonist, that is acts on GLP-1 receptor and GIP receptors in the gut, and this is called as twin creatine. Now this peptide analog of GIP, instead of GLP-1, it is analog of GIP having 39 amino acids and the lipid component, and that makes it a longer acting and rapid tissue uptake also occurs. The drug is shown to increase first and second phase of insulin secretion in response to meals, delays gastric. I mean, these are the common actions of all these drugs. Central anorexic action has also been shown. It improves, therefore, glycemic control, insulin sensitivity, reduces body weight, improves lipid metabolism. Its effects are certainly more than GLP-1 agonists, which are single agents. This agent is a dual. The drug is given subcutaneously with a bioavailability of 80%, has a half-life of about 5 days, and a steady state is reached in 4 weeks. The drug is again metabolized by proteolysis, amide hydrolysis, and fatty acid beta oxidation. Now, usual recommended dose is 5 mg to 15 mg subcutaneously once a week and is available as prefilled. If you compare tirzepatide versus semaglutide in 40 weeks SURPASS-2 trial, it shows that reduction of hemoglobin was much more with tirzepatide as compared to semaglutide, and body weight reduction was also much more, that is 7.4 kg with 5 mg and up to 9 kg with 10 mg as compared to 5.7 kg with semaglutide. Incidence of hypoglycemia was little more but not very significant. Pancreatitis, tachycardia, hypercity reactions were comparable. Therefore, we can say efficacy-wise, tirzepatide outperformed semaglutide in achieving glycemic control, body weight reduction, and at equal adverse events. Now, if we compare weight reduction and glycemic control with long-acting drugs, liraglutide, semaglutide, dulaglutide, tirzepatide. Now, at the usual recommended doses, liraglutide produced reduction of hemoglobin A1C by 1.5% and weight by 3.4 kg, whereas semaglutide reduced weight by 4.3 kg and hemoglobin A1C by 1.3% only, whereas dulaglutide reduced hemoglobin A1C up to 2% and weight reduction of 2 to 4 kg. And tirzepatide once weekly reduce hemoglobin A1C by 2% to 2.3% and reduced weight up to 5.5 kg or 20%. So overall weight reduction, glycemic control have been achieved better with dulaglutide and tirzepatide. Cardiovascular benefits of these agents are remarkable. A significant reduction in non-fatal stroke to the tune of 39% semaglutide and 24% dulaglutide, but no significant differences in rates of non-fatal MI or cardiovascular death. What is more important that secondary cardiovascular outcomes, hospitalization for unstable angina or heart failure risk were also reduced, whereas no reduction in heart failure. Now, in liraglutide group, it has been found that all-cause mortality was reduced. The primary composite outcomes that included first occurrence of death from cardiovascular disease, non-fatal MI, fatal stroke were less in liraglutide than the placebo group, and cardiovascular deaths were lower in lira group. Therefore, liraglutide and others benefits. Now, nephropathic effects, that is renal protective effects, saving effects, semaglutide and others have been shown, that is semaglutide and dulaglutide, they demonstrated significantly greater risk reduction in nephropathy compared to standard of care, that is equivalent to 36 fewer patients with nephropathy events with semaglutide and 15% with dulaglutide. Exenatide ER did not have much effect as compared to the placebo. Therefore, newer GLP-1 and dual agonists are better nephro effect on the lipid profile. Now, liraglutide and others have been shown to reduce LDL cholesterol, total cholesterol, reduce triglycerides as compared to others. And these effects are significant and therefore they will have the important impact on selection of drug in patients with diabetes who have dyslipidemia also. Now, if you compare the currently available newer agents for diabetes, the glutides, gliptins, gliflozins, insulin, glycemic control is achieved by all. Incidence of hypoglycemia is considered much less with the GLP-1 agonists. It may occur with gliptins and gliflozins, that is SLG2 inhibitors. They will produce least incidence of hypoglycemia. Insulin hypoglycemia is well known. Weight loss is found in glutide group, that is GLP-1, whereas not much with other. Insulin may cause weight gain because of anabolic actions. Cardiovascular benefits as risk reduction and renal protective effects are much more with glutides. Somewhat gliflozins are neutral, or there is prevention of renal damage. So therefore, insulin effect would be indirect because of protection due to glycemic control. It's more important, the risk of hospitalization is reduced by glutides, increased by gliptins, maybe reduction with gliflozin, and maybe increased with insulin. Therefore, when there is atherosclerotic cardiovascular disease and we want to give cardiovascular benefits, glutides, that is the non-injectable, non-insulin injectable preparations, GLP-1 agonist or dual agonist becomes the drug of choice, followed by the SGLT2 inhibitors. They produce remarkable risk reduction and cardiac and renal. Like other drugs, there are adverse effects and they include common GIT effects, diarrhea, nausea, vomiting. Nausea is related to stomach illness, and therefore dose increment should be done slowly over a few weeks. Worsening of retinopathy has been found with semaglutide, and we should be very careful in monitoring eye changes. Mild tachycardia, acute pancreatitis are also reported. What is more important, that interactions would be more when we are giving these drugs with other agents. Hypoglycemia with sulfonylurea, otherwise not. Warfarin absorption may be delayed because of changes in gastric emptying. Therefore, INR may be monitored. When we give DPP-4 inhibitors with glutides, more hypoglycemia, less anti-diabetic, poor anti-diabetic control occurs. Now, two concerns are, one is that calcitonin release and hyperplasia of thyroid gland C cells have been found in animals, and this may become very important that patients with family history of multiple endocrine neoplasia 2A, 2B or medullary carcinoma thyroid, these agents should not be given. There is a danger of pancreatitis, I already discussed, and severe renal damage may occur. They are not the drugs for pregnancy at all. So overall benefits to summarize: better cardiovascular outcomes, better lipid control, weight reduction, BP control, preservation of renal function, less requirement of additional glucose lowering agents. Therefore, this becomes a very pleiotropic important effect that will determine choice of therapy in diabetics with dyslipidemia and in diabetics with hypertension and atherosclerotic cardiovascular. Current recommendations are GLP-1 receptors agonists are recommended as first injectable treatment instead of insulin for most patients requiring intensified insulin therapy. GLP-1 receptor agonists are recommended as add-on choice in combination with other agents in hospital and to have a neutral effect on hospitalization for heart failure. GLP-1 receptor agonists are also the preferred treatment choice for people with type 2 diabetes with inadequate renal function. High-dose liraglutide is approved for chronic weight management in patients over the age of 12 with a BMI of 30 or more. Therefore, in obesity, liraglutide and actually oral semaglutide, injectable semaglutide is also approved for the treatment. That is semaglutide 2.4 milligram once a week for obesity. So thank you very much. Those who are interested in knowing more about, few references are there and lot of literature is now available on the glutides and their emerging and important role in the management of maturity onset diabetes. Thank you very much.